and there's no response or anything. What is the degree of loss? Profound. Profound degree of loss as done on behavior. And yeah, pre-treatment, okay, right. So then the first step would be to try out the hearing aid. First step would be to try out the hearing aid. As per the thing, it is 3 months has been fixed for the time, and 3 months of time. In which case, the first it takes about a time anyway, to settle and all that. But in 3 months, you get an idea of how the child is going to progress. If he is not beginning to babble and only vocalizing, if he is not getting much consonant information, then you can make the decision to implant.
But even if he is progressing with the hearing aid,
see, what is the progress is what you have to see. Is he forgetting only vowels? He's only saying and all that, no? But there's no E, there is no papa, kaka, no papa, anything. No other consonants, no vowel E also. Then he's not getting the second formants and all. So if he's not getting the formants, if he's hearing only voice, he will vocalize. He sounds as if it's a very good voice. But then he won't learn speech after that.
Any other questions? Yes, please. Just give the mic. Just give your name and where you come from.
I'm Sanjay Kumar from Patna. Ma'am, regarding my speech perception, as we know, the language zone is in left hemisphere. So in the cochlear implantation, as Dr. Kirtana is doing, is there any right ear advantage you people are considering?
You should have asked this question to Anuradha because she showed the bilateral representation. So I don't think right side or left side really makes any difference because the ascending fibers are ultimately crossed, and again the cross fibers have interconnections as well all the way to the cortex. So I don't think right ear or left ear, or when a right-handed child or a left-handed child, I don't think there is any difference at all. You choose the ear which is audiologically more suitable, radiologically more suitable. And if both ears are absolutely the same audiologically and radiologically, we very often ask the parents, or according to the handedness, if it is a right-handed child, do it on the right side because it's easier for the child to then handle the implant. But otherwise, first of all, the consideration would be audiologically is one ear more suitable than the other. The second consideration, if this is not the criteria, both are equal, then radiologically we'll see where there is better pneumatization or the cochlea looks better, the nerve looks better or whatever it is. If that is also same, then you can go for either side. Any other questions? Yeah? Name and place.
Myself, Sarvanji Shah, audiologist from Ahmedabad. The discussion was going on, bilateral implantation and bimodual, like one ear implanted and the other ear is hearing aided. So which would be the suitable thing? Either, which will give the best performance?
It depends on so many factors. You can see so many children using just the implant with no hearing aid, who say that we don't want the hearing aid, and the others, they will say that we want both. And bilateral implants, they have certain advantages which is already discussed earlier. But I think we need to just see whether the child is able to perceive with the hearing aid and the other, the implant and the hearing aid is doing well. Then it all depends. You have to have all the audiological tests and all that.
Yeah, I think the main issue here also would be financial constraints. I remember we were at a conference and I think I had to finally make this comment to the moderator. I think, look, your way of looking at things and our way of looking at things is different. Because if the implant didn't work together, so just take out the implant and put another one, and we try to salvage an implant if possible. Similarly, anything they would say, oh, just do an implant on the other side, and I said it's not so easy with us because of the cost involved. So if you have an implant on one side and the other side the hearing aid is really not much use, you could certainly do an implant on the other side. But the parents have to pay double the cost, so that is an issue. So if cost was not an issue, And if you had a hearing aid on one side and the implant on the other, and this hearing aid was not really useful in itself, then I think a cochlear implant on the other side would definitely be an advantage. They think, look, your way of looking at things and our way of looking at things is different. Because if the implant didn't work too well, they say, oh, just take out the implant and put another one. And we try to salvage an implant if possible. Similarly, anything they would say, oh, just do an implant on the other side. And I said, it's not so easy with us because the cost involved. So if you have an implant on one side, on the other side the hearing aid is really not much use, you could certainly do an implant on the other side. But the child, the parents have to pay double the cost, so that is an issue. So if cost was not an issue, and if you had a hearing aid on one side and the implant on the other, and this hearing aid was not really useful in itself, then I think a cochlear implant on the other side would definitely be an advantage. They have shown that even the speech discrimination, especially in noise, improves when you have a bilateral implant. You get a little bit of directionality also. Music appreciation is better. All these things happen with a bilateral implant. But the issue is cost.
So if the cost is not a matter, then in the morning it was discussed like if the 1 year electrical signal goes and the other year the acoustic signals are going,
Yeah.
So if both the years, if only electrical signals are going, what would the difference it makes, which would be the suitable thing for the child?
Like I said, with experience, I can say that just one child, but he was, when the second implant is done, as Raki Butala has already mentioned, within the 3 years, both the implants, the child himself said that he can hear all the consonants very crisply, and his production skills were very good, and with just a verb is being misarticulated. So with both, of course, and like it was discussed earlier, electrical and acoustic stimulation, our brain has got the capacity to integrate both of it and understand. So, but of course, if you are bilateral or affordable, they would be the best.
I think Madhuri here is just, 6 months back, 4 months back, you all get your first simultaneous bilateral, the same surgery, both sides. So let's have your views on that.
One thing was the child really loved the sound. She would experiment with it. And the time, first day, she would just, make sounds, listen to this here and that, lift the coil and, everything. She'd bang this, she'd bang the other, and she'll drop some, just to get the feel of the sound. And she did localize well, but of course it's in a very quiet situation and only right and left. Yeah, that was the only, like now it's 2 months since switch on, so that's the progress.
And even sequential, they said if you're going to do it within the first 1 year or so. If you take too much of a gap between the two, then it may not be so helpful. Yeah, any other question?
So what are your results in presbycusis?
Presbycusis results would be very good, excellent results. This lady that we did, that 78-year-old lady, I think that was a presbycusis.
When you decide in these cases, in presbycusis, like definite advantage over the hearing?
So the audiological criteria again, Rajesh? In presbycusis cases, they're using hearing aids and the hearing starts to go down. At what stage would you decide to do an implant?
When you're doing a word test, the word test is scored in 2 ways. Either you score the whole word or a phoneme. If you say bus, so it is scored as a phoneme because 3 phonemes are there, or bus as a whole word. If the phoneme score is 40% or less than that in an appropriately fitted hearing aid, it's below that, or the word score, 20% or below. Now the criterion has gone to 30%. So a person in a calibrated room with appropriately fitted hearing aid in both ears, and if you subject them to word score, if the score is 30% or less in that situation, it's a good candidate for cochlear implant, or phoneme score is less than 40%. If you're doing a sentence test, then the person should be scoring more than 50% or 40%. Now the criterion is changing, as we started the lecture, but now there is changing criterion. A lot of people with severe hearing loss are also going and getting a cochlear implant done, and they are doing much better. And they are the one who is scoring average 40% or 50% or thing. But when they have a cochlear implant, the mean score with cochlear implant is 72% or 78%. So it's quite a high open set score.
Any other questions? Okay, so now before we break for tea, just want to say that I've got a list of the surgeons tomorrow who are going to be the academic section. Now what we have noticed is that some of them who have registered have not turned up today. There were quite a few of you who were asking me whether you could be accommodated. I can't give you that answer till tomorrow morning, because if they turn up tomorrow morning, they're surgeons, so they feel this they don't need and they just want to come tomorrow morning.
So basically the fluid has to resolve before implantation can be considered. The second point is a functional cochlear nerve. Dr. Gupta showed us today morning that a cochlear nerve and a functioning cochlear nerve is very essential for a cochlear implant. And what are the pre-operative measures which are very, very essential? We as surgeons think we can operate, but we require help from a lot of other professionals. And that's what this workshop aims to do. It basically brings together an entire team which is required for a cochlear implant. Vaccination. So our pediatrician basically tells us what vaccination is required. The requisition is that at least 1 month prior to surgery, the child should be implanted. And preferably the vaccination lasts for 1 year. So 1 month prior to an implant, but could be done anywhere up to 1 year prior to an implant. Second thing is confirm that the child is attending a therapy center. As you all know, we operate, but the results are mainly because of the pre-operative and the post-operative therapy. So a therapy center affiliation is absolutely essential. Make sure, otherwise we cannot get good results with implantation. The next thing is confirm that the mapping center is also decided. Once we implant as surgeons and then we do not know where the child will go for mapping, and then we start searching, that's difficult. So either the child goes for mapping at the same center where he gets therapy, or it is a different center. But confirm this in writing. Then of course informed consent. The parents and the relatives have to understand the implications, as well as they have to understand what are the results, what are the expectations, what would be the outcomes. It's essential in this medico-legal context to explain to them and to take an informed consent. Last is preoperative antibiotics. I shall elaborate on it a little later. What we follow here is advice as per our pediatricians regarding vaccination, but what we give is pneumococcal, meningococcal, influenza and Hep B. The implant team, surgical, consists of the ENT surgeon, the anesthetist, nursing staff. We also require NRT, which is intraoperative testing, or rather immediately after implantation testing for the integrity of the implant. So you need support staff. Also during implant or immediately after implant, we do need to take an X-ray with a C-arm. So you require a technician who can take an X-ray and confirm that the implant is actually in the correct position. Which implant? All of you have heard there are so many types of implants available, basically 4 types currently. So you have all these companies, Cochlear, Medel, Advanced Bionics and Digisonic. All implants are good, otherwise they wouldn't be in the market. So all of them give good results. The question then arises, which implant? Well, it depends upon the cost, of course, and various other factors, which you need to discuss with your patients and their relatives before you can decide on the type of implant. Which electrode array to use? In most cases, a straight array is what can be used. In cases of significant ossification, which is common in cases of meningitis, a double array or a split array may be necessary, because through one cochlear tube it may be difficult to cover the entire cochlea. You heard today morning about the newer things that are being developed, the electroacoustic system or the hybrid or the short electrodes, and these are the newer things which are being developed basically to give better hearing. And the curved array or the modulus hugging, which is also, these are the newer things basically to prevent injury to the residual hearing. And we will definitely get more and more improvements in the electrode design. And what are the general implant techniques? This is a list and I will go through each one of these steps. So we have this behind the ear marking site template through which we first and foremost mark out the site. The head is shaved and it's prepared. And that's how we position for the receiver stimulator. It varies with the different implant companies. So it will, but the basic procedure is the same. Marking is very essential to ensure that this receiver stimulator either is not too far away, too lower down, too much in front, and also that subsequently it doesn't protrude out too much through the skin, because as you know, in children the skin is very thin and so it will start protruding out. So there are various factors involved while you decide the actual site. Over the years, the type of incision has been variable. It has changed, as you can see here. A lot of surgeons have described various incisions, comfort level, everything. Each individual surgeon has to decide, but what we do follow is this incision. So after we have taken this incision, the next step is to elevate the skin flap. It's usually an inferiorly based skin flap because the blood supply comes from inferiorly. And opposite to that, when you elevate the muscle periosteal flap, it could be in the opposite direction, so you have a double breasting. That's what we follow, but it could be a variation. Again, individual surgeons follow different techniques. You could have a periosteal flap which goes in front instead. The important thing is that this periosteal flap has to cover the cortical mastoidectomy that is required to be done. Also, this flap also has to cover the receiver stimulator so that it doesn't protrude out. Then there is a template for the receiver stimulator site to decide where exactly and what size do we make the drilling for. And then a drill, the well is drilled. You will see this tomorrow. As you all know, a cortical mastoidectomy is done. The important thing is to leave an overhang superiorly and posteriorly so that whatever electrodes you need to bring out, as in children you need longer wires so that as the child grows, you will need to have this wire extend. So you need overhang so that these wires can be curled around the overhang. The next step is to do the posterior tympanotomy. And the next step is the cochleostomy. Now where do you make a cochleostomy? Classically, cochleostomy is created anterior and inferior to the round window. 1.5 and 1 millimeter diamond burrs are traditionally used. That's a video for a single area insertion. The next step is to actually tie down. Now this procedure varies with the different implants. Some implants have screws to be fitted, while some implants require actual tie-down sutures to fix the receiver stimulator. And then the muscle periosteal flap is brought down and sutured very tightly so that the receiver stimulator doesn't have any chance of shifting. And then the skin closure. An intraoperative X-ray is essential to confirm that the implant is in position. As I said, NRT or mapping, or just to get the values at the time of implant to tell us the integrity of the implant, is essential immediately after implantation. Secondly, after the implant, you can confirm the position with a modified Stenvos view and cover the child with antibiotics preoperatively and postoperatively. These are the antibiotics we use at our hospital: cefotaxime, amikacin, or oral second generation cephalosporin scale base, along with anti-inflammatory and analgesics. Wound care, the mastoid dressing is changed after 10 days and suture removal after 10 days. In children, usually we take absorbable sutures, so we do not have to remove sutures in the 10 days. Antibiotic ointment, and the child and the parents are instructed to avoid injury. Now, MRI compatibility depends on the implant. Up to 0.2 Tesla can be done without removal of the magnet. Up to 1.5 Tesla without removal of magnet with pressure bandage, and up to 3 Tesla with magnet removal. Again, varies with the type of implant. Now, what are the risks and complications of surgery? It involves risks of anesthesia. During the surgery, usually it's injury to the various important structures, bleeding, CSF leak in cases of any incomplete partition or inertia malformations. So you need to explain this to the parents if you know preoperatively that they have any kind of inertia malformation. Post-operatively, patient could have dizziness, reduced taste, facial twitching, tinnitus. The incidence of facial nerve damage is low. With cochlear implants, you really need to be an experienced surgeon and know where to find the facial nerve to avoid damage. Infection is a big criteria, and that's why antibiotic coverage is so essential. Extrusion of the implant and device failure, less than 1% of the cases. That was on cochlear implants, surgical considerations. We'll ask all your questions tomorrow, and I will go on to the talk on bone anchored hearing aids.